I want to welcome everybody that is online, everybody that's watching us from around the world, and everybody that is in attendance. I want you all to know that are in attendance, that since the shutdown of the world, this is our largest audience to date, and I want to thank you all for being here, all right? It is awesome, awesome. So our exhibiting sponsors with Genentech, Banner, EMD Serono, Janssen, who's a division of Johnson & Johnson, Horizon, Novartis, Bristol-Myers Squibb, and TG Therapeutics. All right, and I want you all to thank them for doing this. Thank you. Because they did not have to be here, but they wanted to hear Dr. LaGanke. They wanted to be part of this program again, and this is something that they have done with us for years, and they will continue to do. So again, tonight's program, Dr. LaGanke is going to be speaking with you about symptom management, and he's going to talk about access to care in rural America, and he's going to speak with you about disease progression, as well as, I'm sure he's got other things up his sleeve. Dr. LaGanke, as you all know, he is the medical director and probably the only MS neurologist at the Joan P. LaGanke MS Center here in Coleman, Alabama. And Dr. LaGanke has been part of MS Views and News for a while. I am grateful that he promotes us wherever he can. Thank you.
Well, thank you all for coming out tonight. It's a special night. Hopefully you're going to walk away with a good bit of knowledge, and if not, you're going to ask questions until you do learn something new that you haven't learned before. Last time I spoke up here, I gave my daughter away at the wedding reception, so it's kind of a special place for us here. It's a beautiful place. Thank you to Stonebridge Farms for hosting this evening. So this evening, as Stuart said, we have an agenda of talking about symptom management, various things to do with that, access to care in rural America. Then I do have some tricks up my sleeve as well, some other pieces of information that I think will be very helpful. So I'm going to have some quotes interspersed here, and so this first slide, man does not simply exist, but always decides what his existence will be, what he will become the next moment. By the same token, every human being has the freedom to change at any instant. And these quotes come from someone who's survived the Holocaust at Auschwitz. And so his quotes are in that vein, speaking about how you do have control over some things in your life despite horrible circumstances. All right, so the reason we're here with this condition is we don't have a fix, we don't have a cure, and until we do, we're going to continue to have programs to educate people about MS and keep working towards that goal. We're all unplugged, so I'm unplugged. I'm not bound by any kind of slideshow that's given to me, which is most talks in medicine these days. It's kind of gone through the FDA and through pharmaceutical companies and their lawyers to make sure that things are in a certain way because we're promoting a product or whatnot. Here, I'm unplugged. I can say what I want because I'm not beholden to anybody. So I'm unplugged, and then, of course, unfortunately, people with MS are unplugged a little bit from their brain or spinal cord down to their periphery. So first, I'd like to give the impact of MS. Why are we here? What's the condition, and how important is it? It's very important to all the people in this room. It's important to the people online, but just for people to understand, over 1 million Americans are affected by MS. It's the most disabling neurological condition in the world for young and middle-aged adults. It's fatal, untreated, average loss of life 7 years. That's average. And there are abundant studies that show that the longer we wait to start treatment, generally we never catch up and the worse the outcomes. Next slide. So we're going to start out with rural access to care. So this isn't the exact tractor, but there's a tractor parked at the corner turning into my home. So this is close to home. And we're going to talk about kind of unique things about MS care in more rural America. Okay, next slide. So what is rural? Let's define the term first. It's of or relating to country life, or country people, or agriculture. That's rural. And there's some definitions to be classified as a medically rural place: 35 people or less per square mile. 50 million Americans meet that criteria. And it is true that if there's more of a kind, one is more likely to find a good one. So in other words, if you have 10 neurologists, you're more likely to find a good one than if you have one neurologist, just by odds standpoint. So that's what you get when you're in rural America and you have less choices. You may have a little bit less to deal with. Okay, next. So hopefully we can identify these two people. So we have Dr. Quinn, right, medicine woman from rural America, and we have Bones from Star Trek, probably a more sophisticated urban doctor. Okay, next. Stereotypes. So just to be honest, if you talk to people out and about, and if you went to an urban center and you said, well, what do you think about rural? What comes to mind when you think about rural? It could be kind of rubes or simple people, poor, maybe religious Bible thumping people, racist, simple. That would be some of the things that you would hear from someone in an urban center. And someone in the country explaining what you have in urban areas, maybe self-righteous, wealthy people, maybe more immoral, crime-ridden, not going to church, and but cultured. So those would be sort of just general stereotypes that are stereotypes. Rural healthcare, poorly accessible, and maybe backward would be ways to describe that, and urban healthcare, widely accessible, state-of-the-art. Next. But rural areas are rural, stereotypes are stereotypes. One rural area is not the same as another rural area. So when I talk about this is really generalities, and doesn't hold true for all places. So there are plenty of wealthy people in rural areas. There's plenty of inaccessible care, unfortunately, in urban settings. But my Bible doesn't see color, and it doesn't recommend that I judge anybody. So those terms are not really kind of how I see the world, and hopefully we won't see the world that way, but we do the best we can with where we are and with what we have. So with this in mind, next, what are the potential benefits of having access to good health care? Improve psychosocial, physical health status if a person has better access to health care, prevention of disease, either earlier detection and treatment of adverse health-altering conditions, and improved quality of life and life expectancy. So I think we would agree that if healthcare were readily available, these would be certain things that we would expect or want to have out of that access to healthcare. Next. Barriers to healthcare. So matching of finances and insurance to health services. So maybe there's not health insurance for farmers, let's say, someone who works hard on the farm. They don't have health care insurance and have to pay out of pocket for health care. That's a barrier. Co-pays can be barriers. Then availability of reliable transportation. We have some patients who have cars that are on their last leg, and driving an hour to the next urban area is just not something that is available to them. So that kind of health care is not available, so they're going to get the health care that's local to them. And that's also persons who are disabled may not have a particular vehicle or transportation that would allow them to go very far either. Fuel costs, of course, something else that's come to bear here recently. Time off from work or whatever service to wherever service is available. So if you have to drive, let's say you're in South Dakota, let's say you're in Wall, South Dakota, and you have to drive a few hours to get to health care. Well, it may be difficult to get off from work to be able to make that 6-hour, 8-hour round trip, and there are more rural places than that. So that's a problem to access to health care. Fear of being judged by language. We all know that on television shows, when there's a country accent, it's usually associated with ignorance or something of the sort. And so some people, I think, are fearful that they're not so well polished in their English, and they go to a healthcare facility and they don't want to seem ignorant. Maybe ignorant of medical knowledge, don't want to show off the fact that they're not very adept in medicine or medical jargon, worried about privacy leaks. Some people are worried that others will have access through those computer things and be able to get their information and don't want that to happen. Perception that I'm weak to go get health care. I'm supposed to be this outdoor worker, this farmer or whatnot, and I don't want to go seem like I'm weak, especially more so on the male side. And quality of care rendered. Like I said, in more rural areas, maybe there's not so many different services available, and so that's a problem in accessing care. And then lack of advanced technology and devices. And then there's some providers out in the country may not have very good service. So some of the solutions, which I'm going to talk about in a minute, may not be accessible because there's just not internet service or provider service. Okay, next. So barriers to access of health care are lack of providers, lack of services, transportation, geography. And when looked at a study, Dr. Frayne and et cetera, and other colleagues looked at this, those were issues that led to unmet needs. So things that I talked about, lack of providers, lack of services in general, transportation, geography issues, that led to unmet needs, that led to deficient employment because health suffered, that led to decreased participation in the community because of health issues, and overall quality of life was diminished. Another group, Buchanan and his group in 2008, found that MS patients who live in rural areas had worse quality of life on the physical dimension score, but if they saw an MS specialist, they had an improved physical score compared to an average, what they found to be an average score. If the neurologist was the primary care physician or the primary physician taking care, then the mental dimension, and there's a physical and mental dimension to quality of life measures, the mental dimension was better. And how you rationalize that is that neurologists understand maybe a little bit better the neurological issues and and people feel isolated when they may have neurological issues, especially in MS, fatigue that's not really visible, depression, anxiety, that we understand that those are components where maybe other healthcare providers who aren't very well versed in MS don't really understand that and don't tend to address the mental aspects or psychological aspects of the disease. Next. So Buchanan also in his group, and he's very into quality of life, rural access to care, et cetera, found that barriers such as limited availability of an MS specialist and the greater the distance were the two things that led to greatest dissatisfaction from the patients. So patients who maybe traveled away, didn't see an MS specialist, maybe a neurologist or some other provider, they were very dissatisfied, especially if they had to travel, let's say 4 or 5 hours. I mean, I have people who drive 5, 6 hours to come see me, and if I didn't really I didn't talk to their MS very much, I can see where someone would 12-hour round trip, pretty dissatisfied with the visit. So MS specialty and shorter distance, better satisfaction with the visit. And then individuals who are less likely to see an MS specialist are of the following 4. Generally people of lower family income, live rurally, have a longer disease duration, and are more disabled. More difficult to see MS specialists because frankly there aren't a lot of MS specialists. So I'm the only one north of Birmingham in the state. There are 2 groups in Birmingham and then one further south. So there's not really a lot of access across the state unless you're going to travel a bit in certain parts of the state. Next. So what people from rural areas say were satisfying when they saw an MS specialist were the following: that a treatment plan was articulated and implemented, that a person was more likely to receive diagnostic and maintenance testing, that disease-modifying therapies were more likely to be prescribed, that rehab services were offered and other complementary services were offered. Next. But, in generalities again, if you judge a book by its cover, some MS centers may not provide the services that are really in tune to what you want. They may be a little less personal in different areas, have a different slant. So just going to an MS center and MS specialist doesn't guarantee that you're going to have a productive or satisfying visit. So those things that I was talking about were kind of generalities or results, but they're not an absolute. So what are some of the solutions for people who live more rurally with MS? Well, telehealth, there's some small things that are good about COVID. The generation of more accessible telehealth was something that allowed people to have access to healthcare. Online education, such as a program like this. We're in rural America right now presenting this program, and people from across the country who are in rural areas, hopefully many of them have access. That's a solution to the lack of ability to be able to go to your doctor and talk about things related to MS. And sometimes down-home personal care is undervalued. I remember when I first moved here, I was in Birmingham before I came here, and we had a regional medical center, and I'd see a number of people from Birmingham, Huntsville area, and would have to admit them to the hospital for steroids before we became able to do it more widespread at home. And patients would come to the hospital here from the bigger urban centers. And almost always, they would be very complimentary of the care that they received at the hospital here, saying, I felt like the person actually cared about what happened to me. I wasn't a number in the hospital. And I think that stems from the fact that usually people in rural areas, they're going to know the person in the hospital who's taking care of them in some way, related or friend or through church. And so it was more personal. And I think when it's more personal, maybe the care rendered is a little bit better sometimes. Then country wisdom, sometimes there are some unique problems, like a farmer had this or that to happen, I'm just using that as an example, or something else in a more rural area. Well, the country doctor or the neurologist who lives, it might actually know something about that profession, whereas you go to downtown Birmingham, they have no clue what your job entails or what you're talking about when you say, I have a problem doing X, Y, or Z. So sometimes being in your environment and having healthcare providers who understand that can be of help. Research. So research, we have our research group over here. We do a lot of MS research, and a lot of the studies, the MS research studies, will pay a person to travel to and from their visit. So that barrier, the cost of going to the visit, is erased by entering into a research study. All the MRI scans are paid for usually, medications paid for, close visits and attention. So that sometimes is a real good avenue to offset a barrier of access to healthcare in a more rural area. And this program, so MS Views and News, has done a great job reaching out all over this country, trying to bring information to places that may have a dearth of information about MS and opening up a lot of access. I've been knowing Stu for quite some time and really appreciate what he does. 48 programs in a year sometimes. That's about one a week all over this country. That's phenomenal, trying to bring quality health information to patients from around the country. There are other MS organizations. MS Swim is something that is picking up about remyelination and informing people about all of the things that are available out there as far as MS studies, and really pushing the envelope for remyelination and trying to find a fix for this disease. So appreciate them and those organizations. Next. So other solutions, some insurances in some portions of the country offer non-emergent medical transportation for people if they live in a rural community. So insurance will pay for a person to get to their doctor visits. If it's not going to the emergency room with an ambulance, will pay for that visit. And so some patients get reimbursed, or the family that's had to take them there, it'll get paid for via insurance. something to look into. And then community transportation. So we have a system here that picks people up and brings them wherever they need to go inside the county, as long as they're mobile enough to get into the van. And they're working on those sorts of things to provide even greater access. But for many people, then they can go to the supermarket if they don't have a vehicle, or they can go to the doctor's office and so on from out in the rural parts of the county. The MSAA, Multiple Sclerosis Association of America, for a long time has provided free cooling vests to patients with MS. And that's in this hot area, rural area, has helped a lot of people to be able to work some or go out and do leisure activities in the heat. They also provide a free MRI scan to people with no insurance who have MS every 2 years. So if a person unfortunately falls on difficult times, doesn't have insurance or loses insurance, pretty much you can get an MRI every 2 years. The pharmaceutical companies have been very good at providing free medication to patients who don't have insurance. That's something that doesn't get a lot of press, but that's really valuable to people who come upon hard times. So have their main medication taken care of, have an MRI every 2 years. So one shouldn't just drop out of healthcare, especially with MS, if you lose your insurance. And then GoodRx has been a really pleasant surprise and very helpful for people who don't have great means. So GoodRx bypasses insurance company and offers a rate that's remarkably low for many medications. It's a free app that you can put on your phone, and then you put in the medication because they know where your zip code is, and it'll show you the 10 or 15 pharmacies around you and the cost of that particular drug for you at cost without having to go through an insurance company. And a lot of times it's really remarkably low for some high-cost medications. Next. We're rural here. So to talk about stereotyping places, we're very blessed. I was blessed to be able to come to this rural community 23 years ago. And have loved being a part of this community in all regards. And from an MS care standpoint, then, we have one of the largest MS centers in the country. We have led the country as being a center for handling research patients. In the whole country, we've had more than any other center, including the big Ivy League schools, et cetera, et cetera. We've had more patients enrolled in studies than anyone else for several years during my time here. So we're very keen about research. So in a rural area, you can have, really high-class MS center care research availability. In town, we have physical therapy, occupational therapy, speech therapy, the other specialties that are listed there. We have a hospital. We have a 3T MRI machine, which is the strongest commercial MRI scan that one can get. We have, because of the clinical studies, ophthalmologists, dermatologists, who saw a ton of MS patients through the clinical trials that were necessary to have visits, so became very adept at taking care of MS-related ophthalmologic or dermatological problems. And then we have community transportation, as I mentioned. So yes, we're a rural area, but we are very blessed to have many, many services that overcome the barriers of access to care. I know that's not true in many other rural areas in the country. And so hopefully some of the things that I talked about will be helpful in those settings. Next. So now we're going to kind of jump from access in rural settings to progression of MS. And this is a picture of our disability scale in MS. It's the EDSS, or Expanded Disability Status Scale. It's a rating scale from 0 to 10. They didn't put 0, which is no symptoms related to MS, all the way to 10, which unfortunately is death due to MS. And this is a scale that we use in virtually every MS clinical trial. And it shows us where person is in that scale. It's not a perfect scale. It's very heavily weighted to walking and the ability to ambulate. And when one uses a cane, it's 6, and a wheelchair, it's 7. And distance that you walk between 3 and 5, basically, or 3.5 and 5, it's all related to how many meters a person can walk without stopping. but it served us a very good tool in many studies to get kind of a reference for how people are doing with MS. So this is looking at progressive MS over time. NEDA looks at no evidence of disease activity. So that's what NEDA stands for. Now, I was preaching NEDA, but not NEDA in 2000 when I was here. I was giving talks around the area in Alabama and a lot of support groups. I was really talking about NEDA. One day I thought, well, if I had MS, what would I want out of my disease-modifying treatment? Well, I'd want to have no worsening of my neurological condition, so my exam to be normal. I would want to have no more relapses. And I would want my MRI to have absolutely no new or active lesions. So that's what I would preach. The home run of therapy is what I called it, because the fourth component for me was well-tolerated and safe. So that home run is the things that I would want to have out of my disease-modifying therapy. Well, someone smarter than I came up with the term NEDA about 10 years ago or so, and that's become a goal that's now international, that our ultimate best outcome would be that we had no evidence of any disease activity on an MRI scan, physically by a relapse, or physically on a neurological exam. So if a person achieves NEDA, then there's virtually not much progression. Now, that doesn't talk about cognitive issues, brain atrophy, which is now being added, called NEDA 4, looking at that. But the basic point is, if we can get to NEDA, then we don't have very much progression of MS. And the thought was there was none before, but I'll talk a little bit about that. Next. Now, when a person has a lesion in MS, and they get worse, they progress, well, what happened? Was this a stable lesion? That means the scar that a person had in the brain or spinal cord stayed the same, but aging, we lose neurons. So all of us lose neurons as we age. So was it the fact that that lesion was compensated for by our normal neurons that were around it in the pathway, but then as we aged, we lost some of those, so now that lesion becomes much more evident and we're progressed because now we're feeling the effects of that scar. So that's a lack of reserve. Or is it accumulation of new stressors? So cardiovascular or cerebrovascular disease, if you had a few little strokes or had some other issues that worsened your overall health, is that enough to make you progress and that lesion become more symptomatic? Or is there a progressive degeneration of that lesion? Does that lesion wear out and become more effective over time as far as causing symptoms? Or is there new damage due to a relapse or a new lesion somewhere else? So those would be reasons that a person progresses from their current state of MS. Fortunately, with disease-modifying therapies, we've had a tremendous change in the number of people who've been diagnosed, let's say, with secondary progressive disease, which I'll talk about in a minute. When I was doing my training down the road in Birmingham, it was very common to see people in wheelchairs in the waiting area, very common. And that was my mom's destiny, too. So it was a wheelchair and then bed confined. That was progressive MS. That's what happened. We had no treatments till 1993. After the advent of treatments, we saw about 10 years, 15 years later, we don't have nearly the population in the waiting areas that are in wheelchairs. We knew that the treatments were having a longer-term impact. And unfortunately, although there weren't studies that looked at that, because it's very costly to have 10, 15-year studies, and who's going to pay for that, to prove that going on treatment at this point leads to less secondary progression down the road. A way to bypass that is if you have a country that has registries that label every single person who has MS into their system. And so in Scandinavian countries, they do that. Everyone who has MS gets registered. And they published in the early 2010s a paper that showed significant reduction in the number of people who achieve secondary progressive MS at that point. And the reasoning was that 10 or so years earlier is when the disease-modifying therapies were started. And those were the injectable medications. So the injectable medications, fortunately, had a significant impact on patients achieving this secondary progressive status. And with even stronger medications that we have available now, or more efficacious medications, the expectation and what we're seeing is people aren't getting into secondary progressive disease, which is phenomenally good. So when we talk about progression, traditionally we have talked about primary progressive disease or secondary progressive disease. So primary progressive being a decline in the MS from the very get-go, not an attack and then decline, but just a slow worsening. Let's say a person had a foot drop, and then that foot drop over the next 6 months went up the leg a little bit, and then it kept going up the leg over a year's time or a year and a half time. So not a relapse, I woke up and my leg's not moving very well. That would be more of a course of primary progressive disease. Secondary progressive disease is when a person initially has relapsing remitting disease, and then 10, 15, 20 years later, there's this slow decline of the baseline, that wearing out phenomena, what we thought before. And that's how we talked about progression. But now, in the last couple of years, there have been some new concepts. And so PIRA, which is progression independent of relapse activity, so no relapses and people getting worse, versus smoldering MS versus silent MS, and I'll talk about those in a minute. And then relapses associated with worsening. So a person has a relapse and doesn't completely get over that and continues to worsen with each relapse, so they're progressing with their condition. We've had a terminology change in the last few years. So now primary progressive is not just primary progressive. It's primary progressive that's active with progression, or primary progressive active without progression, or progressive not active with progression, not active without progression. And what that basically means, the active is there are new lesions or active lesions on the MRI scan. And progression means the exam is worse. The score on the neurological disability scale has worsened. So now a person can get worse without having a new or active lesion. A person can get worse because of a new or active lesion. And that's also true with secondary progressive disease. So they also say secondary progressive active with progression, without progression, et cetera. So that's our new terminology that subdivides progressive MS. You don't need to make much sense out of this slide, other than this was a study done looking at interferon versus ocrelizumab in their OPERA studies. And what it shows is patients who have cumulative probability of disease activity, and the composite CDA, which is the very top curve, that's confirmed disability accumulation over time. And what's under it, the blue and the red, are how you got there. So the blue is PIRA, so progression independent of relapse activity, and the red is relapse-associated worsening. So we used to think that people got worse because they had relapses. That was our thinking for a long time. If we could stop the relapses, we'll stop progression, especially early. We'll stop progressive disease. But as you see here, in each of these arms, more disability progression was in patients who didn't have relapses than in patients who had relapses. So this is a newer concept, but it's something that we knew. Our patients just were a little bit worse, and it's like, how did this person get worse? Their scan's stable, they didn't have a relapse. What is it about? What's going on that's causing a person to have progression of their disease? Okay, next. So I'm going to subdivide primary progressive, then secondary progressive, and then go into those other terms, just to give you some background about the progressive diseases. So primary progressive accounts for about 10% of all MS cases. It may be a different condition, because we don't see a lot of times inflammatory lesions with primary progressive disease, and a person continues to get worse. So it may not be like all of the other subtypes that we deal with. Maybe more of a neurodegenerative gene that leads to degeneration of pathways without causing a lot of inflammation. There is a higher percentage of males than in relapsing remitting. So typically, 2 out of 3 people with MS are female. And that's true a little bit higher maybe with relapsing remitting MS. But in primary progressive disease, it's 50-50. 50% male, 50% female. Usually not a lot of clear relapses occur, though sometimes it's overdiagnosed and people miss. Someone had optic neuritis and they had a foot drop, they had something else, and it was kind of subtle relapsing remitting disease. So always want to kind of check the diagnosis. Someone comes in or you were given a diagnosis of primary progressive MS. Am I sure it's primary progressive MS? There is now, fortunately, one FDA-approved medication for primary progressive disease, that being ocrelizumab. We're very thankful to have a treatment because a lot of times these talks, or talks that I've given all over the US and the world, when talking about MS and it would come to primary progressive MS, it's like, I wish we had something for you. And it was just the disheartening portion of the talk always, because there was just all the talk was about treating relapsing remitting disease and everyone excited that we finally have medications and so on, but we don't have anything for primary progressive disease. So we're really glad to have a treatment that we can offer people with primary progressive MS. Sometimes primary progressive is responsive to steroids. I saw that several times in our patients. Even though they didn't have inflammation on their skin, they responded to steroids and would improve for periods of time, and we'd have to give periodic steroids. So we still want to treat symptoms aggressively, comorbid conditions aggressively as we can in primary progressive disease, as we would any other subtype. In the past, maybe there was a tendency to say, yeah, primary progressive, we really don't have anything for you. Or if the ocrelizumab, let's say, didn't work, I'm sorry, we don't have a whole lot to offer you. And that's in the sense of disease modification, preventing new things from happening. But we certainly had a whole lot of things to offer symptom management and improve quality of life. But I think that wasn't always offered. And so people with primary progressive would just go home and they wouldn't come back to the clinics. They didn't see any point in coming back. And you'd see someone 5-6 years later who hit a different point in their disease that required some other kind of care, like nursing home care or something else that they had to go through the healthcare system. So we need to treat people with primary progressive as aggressively as we can for their symptoms and quality of life. They're people just like anybody else. And we want to prevent general health worsening, because general health worsening affects all of us. So if you have MS and you develop diabetes or hypertension, it's not very well controlled, or some other conditions, your MS is not going to function as well. MS doesn't deal with stress very well. So we need to be very vigilant in our primary progressive patients as well about general health worsening. And then use a DMT if it's appropriate. Secondary progressive disease, some questions. Is it really progression? Or as I mentioned, is it just aging of normal neurons over time? And it's really not progressing, it's just you feel more the effects of lesions because you don't have the reserve that you had before. What happened, as I kind of alluded to before, is that we didn't have studies looking at secondary progressive disease and the impact of treatments early on. And so what happened nationally and through insurers was, if you get a diagnosis of secondary progressive disease, there are no medications approved for disease modification in secondary progressive disease, you can't have an MS disease modifying therapy. Just because we didn't do the studies doesn't mean they don't work, right? And a person with secondary progressive, more advanced disease, maybe only can use their arms or one side of their body. Aren't those the people who most need us to maximally control their disease so they don't have any more lesions to occur that could take their good hand or affect their cognition? But a big mismatch in that a lot of secondary progressive people not treated with disease-modifying therapy that could have been very helpful to them. One question is, when does it really start? How do you define relapsing remitting now you're in secondary progressive disease? And that has some challenges to it. Typically it's been if a person goes 6 months with a worsened neurological exam, or they have a worsened exam today and 6 months later it's the same, still that worsening, and they didn't have any relapses. Then we would diagnose someone as having secondary progressive disease because they progressed without any relapses visible. Now, B-cell follicles, or B-cell follicle-like structures, were discovered with COVID, it's kind of a void. Maybe 10 years ago, my time is not so great because of that 2-year hiatus, but maybe 8 to 10 years ago, some investigators found these B-cell follicles inside the brain. So typically, those are things you see in your lymph node or your thymus or in your immune structures in the body. And to find these immune centers behind the Iron Curtain inside the brain, beyond the blood-brain barrier and on your meninges was really astounding. And it made us really rethink a lot of things. So we see more B-cell follicle-like structures in people with secondary progressive disease. And we see it with those who have secondary progressive disease of younger onset and those who are more disabled. So we really think these structures are causing a lot of havoc on the other side of the blood-brain barrier. And so treatment should be geared towards that. A lot of research is being geared towards that. So to kind of talk about, in general, secondary progressive MS, it's a transition from relapsing remitting MS with a gradual worsening of neurological disability. As I said, not without a relapse. And it's this worsening without remission. So the baseline is getting worse. That's why we call it progressive, because the baseline is progressing. It's neurodegeneration from damage in the white and the gray matter causing demyelination. And it's also a loss of neurons and those connections between neurons, what we call synapses, in the cerebral cortex, so the gray matter, the outer portion. So that's what we see in secondary progressive MS. And it correlates with the amount of pathology in the gray matter. We always thought that MS was a white matter disease, the cable system of MS. But now we know that the gray matter is significantly affected in a number of people, and in secondary progressive MS, especially so. So people with secondary progressive disease had more disability related to how much pathology was in the gray matter, not the number of white matter lesions that they had, which is what we count on our MRI scans. Next. So the meninges or leptomeninges are the things that cover the brain, and that's where we see these B-cell-like follicles. So when you have inflammation from there, that drives a lot of the progressive MS that we see. And we haven't been treating that. We haven't been thinking about progression of MS in those terms. So like I said, that's kind of changed our thinking of we need to treat those follicle-like structures and control what kind of chemicals and cytokines that come from there that stimulate the degeneration of the neurons. So it's a new kind of approach that we have towards stopping progression of MS. Next. So whenever you see this, a nice landscape kind of picture, you're going to get some immunology, okay? So just kind of warning you, look at the beauty, and then immunology is a little bit sophisticated, a little different kind of an animal, but I think it's important maybe to understand the underpinnings of what we're looking at. So this is a beach that our family goes to often. Microglia. Who in the audience has heard of microglia before? So in the local audience, it's only a handful or so. So if you break that down, micro, small. Glia are the support system cells inside the brain. You have to have structure. If you had a bunch of cable system and you didn't have anything holding them together or apart, it would be a big mess up there. And some of us have a big mess up there, but it's not because we don't have glia. So microglia, small support system cells. About 10% of our brain cells are microglia cells. We haven't paid much attention to them. They get stimulated when we have an injury to the brain from MS or head trauma, and they look for infections that may occur, or pathogens in the brain. And this little microglia is an interesting guy. He has a process that's kind of scanning. So it's like an amoeba that has a portion of the cell that's kind of moving, looking around inside the brain for injury or for infection. And when you have an injury or infection, you release some chemicals that this microglia is able to detect through its modal process or its moving process. Now, microglia we see do a lot of things. So they facilitate synaptic plasticity. That's a big mouthful. So synaptic plasticity is our ability to learn. Plasticity is our ability to get better over time and our reserve of brain function. And so microglia help connections occur in the brain that are more useful and beneficial. And it maintains these networks. So inside the brain, there are billions of cells. And one particular nerve cell is going to have a lot of input that's positive, turn it on, and a lot that are negative, turn it off. And it's the balance of positive and negative that determine what kind of signal is going to go downstream and affect another function. And so the microglia are very important in making that environment connect well. And they also connect to the neurons or the neuronal cell bodies and protect them from injury. Next. So in other words, microglia prune synaptic inputs. So all the inputs, they kind of prune out the ones that aren't necessary and kind of hone in the connection so that things are very efficient. They remove dysfunctional networks. They protect the functional networks. They promote remyelination. That's a biggie. And they remove pathogens or other products of inflammation. If you have head trauma, stroke, MS attack, well, where's all that stuff, that inflammation going to go? The microglia take care of it, and they get rid of it. And so that's really important things that those little small glial cells do that we're learning about. So if you look at this garden, talking about rural America, well, one has to do a lot of pruning, and one has to do a lot of fertilizing, getting rid of the old and the damage. So this is kind of how I look at the gardener here is the microglia. Very important, but also remyelinates, which is also potentially very important. Next. Now, I was saying all these nice things about microglia. Well, and so on the one hand, microglia restore the homeostasis or the balance in the brain by changing the shape and the function when you have an injury. So microglia kind of gets you over the injury and reestablishes some kind of sanity to that area. Gets rid of the inflammation and lets the connections be reestablished. That's the good side. On the other side, microglia can actually accelerate degeneration of the brain and progression in MS. And that seems, and in many other neurodegenerative conditions. And we'll talk a little bit more about how that happens. Next. So the little guy down there on the bottom right is Benedict Arnold. And so there was a study that looked at microglia in a certain way and saw two distinct types of microglia. Microglia 1, microglia 2. And they're very different in what they do. And it seems like maybe we start out with microglia cell type number 1, and that's doing all those wonderful gardening things that I talked about in the brain. But over time, they lose their protective allegiance, and then they lead to degeneration of the neurons. So kind of a Benedict Arnold situation. Oh, it was a good guy, and now he's turned on us, and he's leading to more problems inside our brain. And here, you don't have to understand much of any of this other than there's a nerve cell connection pathway here, and depending on the environment, you're going to have the green one or the blue one. And you want the blue one, not the green one. But it all depends on the environment. So the environment seems to shape what kind of microglia you're going to get. And that's really important in MS. What in the MS environment will lead this microglia to not remyelinate, but actually cause more progression of disease. And the next slide shows just kind of the different chemicals that each one puts out. So you can see, although they're microglia, they're very different in their function. Same cell, same type cell, but depending on how they're turned on or turned off, you're going to get one result or another result. And I'm sure this is a simplification, that there are other subtypes as well, but that's what we understand today. And so one of our challenges is how do we give a therapeutic or something that's going to maintain the good microglia and help do all the wonderful things that microglia do, and not allow it to turn into this Benedict Arnold that leads to progression of MS over time. So that's a subject of a lot of research at the present time. So I'll read this. Dostoevsky said once, "There is only one thing I dread, not to be worthy of my sufferings." These words frequently came to the mind of the person who wrote this, who was in the concentration camp. After I became acquainted with those martyrs whose behavior in camp, whose suffering and death bore witness to the fact that the last inner freedom cannot be lost. It can be said that they were worthy of their sufferings. The way they bore their suffering was a genuine inner achievement. It is this spiritual freedom which cannot be taken away that makes life meaningful and purposeful. So that's a concentration camp. Someone who's ravaged with MS, they face a lot of challenges. And they have the ability to perceive how this has affected them and what they are going to do with their life and how they're going to deal with a most awful situation. And so here, the comment is about being worthy of your sufferings. Despite suffering, how do you deal with things? Your responsibility for being a good human being doesn't go away. It's a lot more challenging to manage day to day, but in doing that, you move the world. People who have disability and continue to go on have a huge, huge impact in this world. It's so inspirational, mostly to the ones, or most to the ones right around the person who's persevering, but also to people who just know of that person who's continuing to fight on in a very difficult situation. That's inspirational. That's what makes a difference in this world. People who have normal health, bebop around, 2 kids, picket fence, cat, dog, go to church on Wednesday, go to church on Sunday, great stuff, good stuff. And it may change the world in some aspects, but it's not as powerful of a mover as someone who has great challenges and continues to go on. That changes the world in a more acute and dramatic way, I would suggest. We all saw those television ads where someone holds the door for someone, and then that person who comes in picks up the paper that the person in front of them dropped, and then the person holds the elevator for the next person. And I think we all get touched by that a little bit. We all think that's really a good thing, and it kind of speaks to the same sort of issue. Next. Now, newer concepts in progression. So I talked about primary progressive MS, secondary progressive MS. Well, what's smoldering MS? Well, it's an idea that there's some chronic, active, slowly progressive white matter lesions, that they don't pick up the dye. It's not a whole large area, but it's just a tract that deteriorates a little bit at a time. As opposed to silent MS, which is worsening disability, we don't see any new lesions or progression of lesions, but we see a lot more brain atrophy. Something's happening to cause more shrinkage in the brain, and that's silent MS. And then PIRA, which I talked about, progression independent of relapse activity, is worsening without relapse. So that kind of encompasses smoldering, silent, secondary progressive MS. And all of this came from the fact that enough people spoke up to say, our thinking is wrong about worsening is related to relapses. We see a proportion of people getting worse without relapses, and we need to understand this because, as I showed in those 2 particular studies, it accounted for more of the disease progression than those associated with relapses. And all of the patients, or all the people in these studies that led to the smoldering MS, silent MS characterization, all seem to respond to disease-modifying therapies in some way. So it wasn't egregious inflammation that you could see in the brain, but something was going on that seemed to be responsive to our disease-modifying therapies. Next. So smoldering MS occurs both in primary progressive and secondary progressive MS. It's slowly expanding or evolving lesions. And here it's believed to be to that microglia, the bad microglia activity that leads to this neurodegeneration that occurs. And it may be that a person has demyelination from a relapse back when, and then we thought that lesion was scarred over and done, but it really wasn't. It started to try to remyelinate, because the brain tries to remyelinate, but it couldn't do it for whatever reason. And then it goes into this next phase of, well, I'm not just going to stay quiet like a scar on my skin. I'm going to continue to cause more problems. And that's kind of where we're at thinking about smoldering MS lesions at the present time. And so some of the lesions in the brain, when we look at an MRI scan and we see a lesion here, a lesion there, a lesion there, they're pretty close, and then over time, they all grow together, so it's a big blob. Well, maybe that was the small lesions at the edge just kind of getting worse, and the other one from the other lesion getting worse, and they come together, and now you see this area of damage. It's not the one lesion that we saw before. Next. The silent MS, this is the one where you see atrophy. So you see brain atrophy without any new lesions. But silent MS in a different sense is 9 out of 10 brain lesions on average don't cause any symptoms. So that's a different kind of silent MS. That's why we get an MRI every year, not for other reasons, just to get an MRI scan, but it's because the disease can progress under the radar screen. You don't feel it and I don't see it. And yet, if you have 4 or 5 new lesions, we know what we're doing isn't working, and it's probably a matter of time that you're going to run into some problems. And if 1 out of every 2 relapses leads you to be permanently different, we don't want to wait till you have a relapse to then go ahead and treat this situation. So that's why we do these maintenance scans, to look for any evidence that this disease is moving under the radar screen. So the most recent study, it was this year actually out of Brazil, demonstrated 20% of their patients had a significant increase in brain atrophy in their MS patients without any change in lesions whatsoever. So that's another, how does that happen? We don't know. Next. I talked about PIRA, and this is kind of the reasoning behind it, a large study that was done that kind of looked at patients who had progression independent of any relapses that occurred. And it was a long study, averaged 6.5 to 17 years. So just the new concept, just wanted to give you some background as to where this came from. So we're trying to understand, it's not as simple as you have relapsing remitting, you go into secondary progressive disease, or you have primary progressive disease, and that's MS. No, there are other things going on that we need to know about. Next. This would be a picture of the study looking at patients who had worsening with relapses and patients who had worsening with this PIRA. And the point being that more worsening over time, or brain atrophy, occurred in patients who didn't have new relapses compared to those who did. Okay? And there are certain areas of the brain where you see this. So in this particular picture, the top left corner is the whole brain, and then over next to that is the thalamus, and then below the whole brain is the caudate nucleus, and next to that's the putamen nucleus, which are nuclei in the middle of your brain. And so when you look at the blue, that's the amount of atrophy in the brain that is due to MS, an MS lesion. And then you look over time, well, aging at the age of 60 in that top left-hand corner picture, now aging accounts for most of the atrophy that you see in that particular structure. The bottom 2 nuclei don't seem to be affected by age. MS still seems to be the predominant cause of atrophy, no matter if you're 30, 40, 50, or 60. So maybe those are structures we should look at, so that we don't have a contaminating aging problem when we look at somebody who's getting worse and we're looking at other places, and well, that's because they're aging and they're having more atrophy just from natural aging. So that's something that we're focusing on now. Just like we changed relapsing or primary progressive and secondary progressive terminology, there's some terminology associated with PIRA. You don't really need to know these exact things, just that they exist, that we look at PIRA less than 5 years, over 5 years, whether there was associated with any lesions in the last 2 years or not. Who has PIRA? What do those patients look like? So early PIRA, so that happens within 5 years of having a diagnosis of MS. Those patients are typically older, more spinal cord disease, fewer brain lesions, and fewer relapses, and their prognosis is worse. So if you think about it, if you're older and get diagnosed with MS within 5 years, not a lot of relapses, a lot more spinal cord affected, and you're having this advancement of disease without attacks, you're probably going to have a worse outcome than the other. We're trying to further characterize this idea of progression without relapses, which we haven't thought about ever before the last 5 years or so. Next. So what do we do to slow progression? Well, when it's relapse-associated worsening, we use a disease-modifying therapy to stop the relapses, to stop the relapse-associated worsening. And that likely will have some effect on the progression independent of relapse activity. And then the other thing we can do if you have progressive disease is make sure we're doing all we can to keep blood pressure down, blood sugar well, hydrated brain, etc. All the other good health things we can do, because those cumulatively add to worse outcomes. So if you're having some progression of MS and you're having a lot of stressors from these other things, I would expect that you're not doing as well as the person who's maintaining good general health and having some progression of their MS. Next. So 3 quotes. And the book is A Man's Search for Meaning, and it's from Dr. Frankl. That's where these quotes are coming from. So he said, we're no longer able to change this situation. We're challenged to change ourselves. So a lot of people buck their disability. They get to a point and they give up. It's like, well, this is hopeless now. You know, I went to therapy, I did this several years, I'm in a wheelchair, I can't do this or I can't do that, and that's how it's going to be. So they don't change their perception of, okay, this is the new territory, what am I going to do given this situation? And an abnormal reaction to an abnormal situation is normal behavior. Right? So if you have something abnormal to happen, you're probably going to respond abnormally, and that's normal. In some ways, suffering ceases to be suffering the moment it finds a meaning, such as the meaning of sacrifice. So if you think about the people in the concentration camp who were suffering badly, when they ceased to think that suffering was all their meaning, that their whole life was just suffering, they had some meaning to their life. The one who shared his bread with the comrade who lost it in the mud or the frostbitten hole they were digging. You know, that you found meaning in the suffering and you didn't suffer as much. So when you're suffering, when you're having problems, doing positive things help you not to think so much about your suffering. Right? This would be another way to look at that. Next. Now we're going to switch to the last portion, which is symptoms and symptom management in MS. And we have to be aware of the terms symptoms and comorbidities. So symptoms are neurological issues that a person has related to their MS. Comorbidity is a separate condition that, boy, you're lucky to get the genes of MS and depression. So you get anxiety and depression. Or you get some other genes that come on as a package deal with the MS. That's a comorbid condition. That's not a result of having MS and now you have stiff walking. It's another condition that is tacked on to the MS, and there are a number of comorbid conditions that come with MS. Next. Let's say we get on a really good disease-modifying therapy and you don't have any more relapses. Well, you still have to deal with the baggage of things that happened before you came to the point of diagnosis or after early inadequate treatment. So I like to look at symptom management as a quality of life box. And that's when we're looking at medicines that treat the symptoms. We have a medicine for tingling in your left pinky finger. But is that really improving your quality of life to take a medicine at a cost that may interact with another medication to take care of that little tingling that's not interfering with anything? Versus fatigue, the most disabling condition in MS, or symptom in MS, treating that probably worthwhile most of the time. So you put the symptom management in terms of, is my quality of life better for having done this in balance? The treatment of symptoms doesn't directly affect whether you're going to have more lesions or not, at least how we think about it now. And as I said, balancing improvement versus side effects of a medication, etc. And I'm going to focus mostly on the medications that we have. There are a lot of other physical therapy, speech therapy types of things that are offered that are also very, very valuable. Next. So individual to individual varies. This one person may have very mild fatigue, another person has very significant fatigue. One might choose to go on treatment, the other one would choose wisely not to go on treatment. So just because you have a particular symptom doesn't mean you're going to be treated all the same. First symptom, frustration. I see it, I can't tell you how many times every single day in clinic people say, they don't understand me. They don't understand my fatigue. They say, yeah, when I say that to my niece or uncle, they go, yeah, I get tired too. Or, yes, I have that problem too. And they don't really understand the day-to-day issue of this particular condition or the effect of it. So frustration is a huge, huge symptom, not feeling like you're connected. Next. So MS misunderstood. I'm so sick of not being understood. What do you mean? All right, so, next. Next. And so in that, with family or friends, no man should judge unless he asks himself in absolute honesty whether in a similar situation he might have not done the same. Right? So if I was in those shoes, maybe I would be feeling this way or that way as well. And the biggest frustrating part that I see or situation is when the caregiver, spouse, whomever that is with the person afflicted with MS is as healthy as a horse, never took a medicine one day in their life. They do not understand what's going on. And some of them will, come to the visit, try to understand and learn, and some that's just you're giving in, you're just not really trying hard to fight this condition on your own. So we see a lot of that as well in clinic. We'll go on to the next one for time. So hidden symptoms. So this is where the frustration comes in most great. Fatigue. Anxiety and depression, which is also a comorbid condition, those can be symptoms as well. The most common cognitive problem in someone with MS is slowing of processing complex information. So speed of processing complex information is slower because it has to go through a scarred area. It takes longer to kind of understand. It doesn't mean a person's any less smart. So our kids with MS, we write often to give them more time on the exam. It's not an unfair advantage. It takes them longer to kind of read the question or get through. It's just the fact that it takes longer to understand. And when you add that to the second most problem cognitively in MS patients, which is attention and concentration, that's not a very good combination. If it takes you longer to understand something that's complex and you don't have a very good attention span, you may not understand that very complex, that piece of complex information. At work, we changed a new computer system at work, and I'm having a dickens of a time trying to understand this new system at work. And it makes a lot of sense why. But hey, you got to pick it up or you're going to not be working here anymore. Bowel, bladder, sexual problems, we don't see that very readily. Dizziness, optic neuritis or blindness, partial or otherwise in your eye. Guilt and shame of having the condition and not bringing in money anymore and being dependent on other people, and pain. All of those things you cannot see by looking at someone, just straight out. That's a lot to deal with in some people, and some people have most of these things. But in fairness, the person next to you doesn't deal with those things. They can't see it, and we judge people a lot appropriately because we can't interview everyone. So you see someone who's kind of unshaven, hair's out, their shirt's untucked, and they're coming into work. Well, they probably hung one on last night. They're a little bit hungover. They had some kind of issue or something. We make those judgments. But someone else with MS and significant fatigue says, I'm really tired. And you look at them and you go, you don't look tired. I'm tired too from X, Y, or Z. It's not a sleepy tired. It's an internal tired. I have nothing left in the tank to give because my mitochondria have been overworked in my central nervous system, and I just don't have the energy reserve anymore. But it's hard to understand that if you don't have it because you can't see it. So kudos to all who came who don't have the condition and trying to learn and understand this condition more, because it's not so obvious just looking at somebody. Next. Common symptoms are listed here. I'm not going to go over each of these. I will discuss them in brief in the upcoming slides, but these are the more common symptoms that someone with MS has. Next. Mitochondria. Way back in biology. Remember those guys? The powerhouses of the cell. There's what generate your ATP that lets you be here tonight and actually function in most everything you do. Very important little guys. So they give us our energy. They generate our energy. They also store calcium, which kind of regulates the balance of cells, nerve cells. So whether your nerve cell survives or it doesn't when it has an MS attack. It helps with signaling of cells, and it also regulates cell death or apoptosis. We don't need bad circuits to continue, but unfortunately sometimes good circuits die as well because of malfunctioning mitochondria. They uniquely, of all cells, those structures have their own DNA and nuclear DNA. So they have their own DNA supply too. Next. So when you have inflammation from MS, you have a change in your potassium, sodium, and your channeling in your cells. And that's a stress. That's an oxidative stress. And so that leads to these reactive oxidative substances, these bad things that attack your tissue. And so then it kind of further increases more and it kind of begets itself. So the more swelling and damage you have, then you generate more free radicals, and that generates more over time. So we have an imbalance in our energy, and that's the reason I'm saying that, is that mitochondria are important for our energy, and when the mitochondria stop functioning so well and they're overly stressed, you're tired at noon. You don't have any energy left at noon, 1 o'clock. You've used all the energy we will use in a day by that time because that's all you have in your tank. Next. And so this kind of shows how important mitochondria are, and that there are a lot of things that lead to missteps if the mitochondria are dysfunctional. The mitochondria you were born with are still in your neurons. You don't make any new ones. They live with you till the end. So those mitochondria in your nerve cells from the brain have been there from the beginning. And so when they get taxed with a lot of inflammation and stress over time, some of them die, some of them deteriorate, some of them just don't function so well. So that's one of the reasons we have this significant fatigue in MS that no one can see. Next. And this kind of looks at mitochondria death over time. So if you jump to the third, or the C row, you see the red mitochondria. He's not doing very well, and he's going to end up dying. So basically over time, when you deal with more stressors, you create more of these mitochondria that can't really survive over time. And that's from the inflammation due to MS lesions that causes this stress. Next. Number one disabling symptom of the number one disabling neurological condition in the world for young and middle-aged adults is fatigue. It's a real player. And like I said, it's not visible a lot of the time. It's not sleepy tired. It's due to an imbalance. Some of it's due to an imbalance with mitochondria. And so we tell patients to pace themselves. Well, some of you are type A people. That doesn't go too well. So, hey, I have good energy today with my MS. I'm going to clean the whole house, and then I'm going to be in bed the next 2 or 3 days, and then after that, I'm going to get up and do it again. And it's hard to pace yourself when you finally have a really good day. But I think it's wise to learn how to do that. Like that quote before, situation changes, you change. Right? Learn how to be a kid's roller coaster instead of an adult roller coaster. Good this day, bad for a couple days, good, bad, versus, okay, I'm only going to do half of what I really feel like I can do, and then I'm going to kind of keep my reserve, so it's going to be more like this. We have to address other causes. It's easy to say your fatigue is due to MS, but if you're not sleeping well at night because you're getting up to go to the restroom 5 times, or you have cramps all night long, or your muscles are spasming, and you have sleep apnea, and et cetera, et cetera. You have infections, recurrent UTIs, you're going to have a lot of fatigue from all of those things. So we need to make sure we're addressing all the other issues and not just treat fatigue with a medication and say that's the whole treatment for fatigue. Next. So how do you manage fatigue? Fatigue management in the middle, treat sleep disturbances, improve mobility. Because if you're very stiff like so, if you're flexing your biceps unintentionally from your spasticity, you're chewing up a whole lot of energy that you don't really have. So if we can relax those muscles, you have a lot more energy to deal with things. Anxiety, depression, anxiousness burns calories, burns ATP, not for useful purposes. So treat the anxiety to give more energy. Conserve energy. Don't go out in the middle of the day in the heat. Treat infections when they're there. And then there are medications that can be helpful for the fatigue of MS that we often employ. Next. Speech dysfunction. I would dare say most in the audience, both on the other side of the camera and here, have some difficulty with word finding from time to time, more so than the rest of us. Or the wrong word jettisons out of your mouth. Or you know what you want to say, just can't come up with it. Or your thought that you're talking in a conversation just leaves you and you have no idea what you're talking about. Really, really common in MS. Where the lesions are located, they create this situation very, very frequently. There are some types of speech pattern that are due to the balance center. It makes it a very staccato type of a speech, kind of a cerebellar speech. So there's lots of different ways that MS can affect your speech. Next. So cognitive dysfunction, I talked about some of the things that occur with cognitive dysfunction. A lot of times, cognitive dysfunction we find is related to fatigue. And if we improve fatigue, we improve cognition. So it's not that you're going down the Alzheimer's road or this is how it's always going to be. And just how I think about it a little bit helps me to address the issue is that the primary purpose of energy is to get you through the day. Cognitive functioning, memory is a luxury. You got to make it through the day first. So all that energy spent on cognition is extra. So if you only have a bare minimum, your cognition's not going to be so good. You're not going to spend that energy on memory and other cognitive issues when you're just trying to make it through the day with a decent amount of energy. So there are medications that can treat the cognitive dysfunction when it's truly independent of fatigue, but maximizing treatment of fatigue and depression often leads to a significant improvement in cognitive functioning. You want to do memory exercises. If you think about something, do it then. Don't rely on your memory to get back to it. As far as multitasking goes, that's very difficult. When you're talking to someone, there's noise over here. There's a dysfunctional MS pathway, so it comes in through the hearing, it hits that scar, and it's coming in one way, and you're listening to this person here, and then the bird's flying by over there, and it's like, I can't do this. So in those situations, it's wise to just say, okay, what you have to tell me is very important. I need to turn off the television. I need to pay attention to you, and I don't need a lot of other things going on to have so that I can understand what we're talking about in this conversation. Checklists, staying organized, and again, there it is. Different situation. You're not usually the organized type of person. Well, it's a different situation. Probably a good idea to become an organized person if you want to remember things and get things done. Next. So love goes very far beyond the physical person of the beloved. It finds its deepest meaning in his spiritual being, his inner self. Whether or not he's actually present, whether or not he's still alive at all, ceases somehow to be of importance. So this talks to love. It's a concept. It's how you feel, and it's based on a feeling about maybe somebody else, something else. That somebody else may not be here. So what helped this doctor get through his time in the concentration camp was he thought about his wife. And it gave him pleasant thoughts in such a terrible, awful thing. And he thought about sunsets where he'd walk with his wife, and that love was able to get him through this situation, knowing that, or hoping that that was going to happen again someday. But even the knowledge that I can generate a positive feeling in my brain, that I have control over that. The Nazi soldiers don't have control over how I'm going to feel. I can generate that. Was really important to him, that he could perceive this situation and not have PTSD or bitterness. He wasn't going to allow them to do that to him. He could make a decision of how he could feel, and he did it with starting out with the concept of love. So when a person has a disability, a medical problem, an issue, there are places you can go to control how you perceive, how you change the situation. It's not everyone who has this has to feel like this. Where does it say that? You have the power, you have the freedom to perceive how you feel about a given situation and what you're going to do with that situation. Next. So anyone know where this is? Sagrada Familia in Barcelona. It's going to be finished in the next few years, world's largest church. It's really amazing to see. And every little image and stone has particular meaning. It's an astounding place to go. Next, so something really important to see. Well, there can be visual problems in MS. So optic neuritis, very common. Double vision, nystagmus, which is that jumpy vision that you can have. Intranuclear ophthalmoplegia, where one eye goes here and the other one stays there. Those are things that typically or can happen in patients afflicted with MS. Optic neuritis is the most common. About 25% of people will have optic neuritis as their presenting attack of multiple sclerosis. And there are treatments for that. So lots of different ones. So IV treatment, as opposed to oral treatment, is recommended based on a study that looked at patients who had optic neuritis were treated with oral steroids or IV steroids, and the people who were treated with oral steroids ended up having more attacks and actually diagnosed with MS, much more so than those who got no treatment or those who had IV treatment. So something about the oral steroid being the sole treatment of optic neuritis seemed to predestine that person to have a higher chance of developing MS. Next. Double vision, usually in the brainstem. Type of double vision, whether they're side by side, diagonal, or up and down, tells us where the lesion is. And sometimes it's a little hard to tell in the brainstem, but how the pattern of the double vision is will tell us. And just something that comes up several times a month is my eyes I have double vision. Well, is this in your eye or is this in your brain? If you cover one eye and it goes away, then it's probably in your brain. If it doesn't go away, it's in your eye, okay? And that's something that says you don't need to go see the MS doctor if it's in the eye. You need to go see the ophthalmologist because there's something going on in your eye. So next, I'm going to kind of breeze through some of these just for sake of time and to get to some questions. Paresthesias is tingling and numbness. So tingling and numbness, one side or another, very important to us. So if you have tingling and numbness that starts in the feet and works its way up the leg, you have a spinal cord problem. If it's in one side, it still can be in the spinal cord, but it also can be in the brain. So it kind of tells us where the situation is. And if you go to a doctor with tingling and numbness going up your legs and they get a brain scan and they don't see anything and they send you home saying, well, I don't see anything, that's not good. So being empowered with knowledge is helpful. Say, hey, don't you think we should look at the spine because both legs are affected? And if both legs are affected, it would have to occur in the brain on this side way over here and this side way over here at the same time, two separate lesions, probably not happening. But the pathways run right next to each other in the spinal cord, so some inflammation there is going to affect both legs. Right, so having some knowledge of this can be very helpful in how you get to treatment. Plus, spinal cord lesions are more devastating typically. They're the ones that are responsible for motor disability in patients far and away. So if you had some tingling in both feet working its way up your ankles, I better post-haste get some treatment. As opposed to, my hand's a little tingly, I'm not sure if I slept on it wrong or this or that, I'm going to kind of see what's happening over time. That may be a valid way to look at things. So knowing disease location and symptoms, I think, is important for you all. Weakness. Same thing, one-sided, both sides. So you start out with a foot drop on the right, and 2 days later, now the left foot's dropping, you have a spinal cord problem most likely. spinal cord or brainstem. So you need to go get that taken care of post-haste. Physical therapy has been considered of limited benefit to restore function, but is good for maintenance and to get people going. And very early, if you have weakness from a relapse, very important to help you get going. But if you have chronic weakness, it's really hard to regain that function because you lost the wiring. You only have a certain amount of wiring to that muscle, and you can only do what you can do with that wiring. Problem I see, though, is that people who have weakness tend not to use that limb. And if you don't use that limb, now your muscle shrinks. So now you have two problems. You have a wiring problem, and you have a muscle atrophy problem, and your weakness is compounded, and you're worse. So you want to make sure you have weak muscles, you continue to use them some to maintain the muscle strength, or that limb is going to likely get worse. And we think it's progressive MS. It's not really progressive MS, it's atrophy of the muscle because we didn't use it. Dalfampridine or Empira is a walking pill which can help restore function to weak muscles. It's the only thing really we have that can offer that help. It's not going to offer that help to everybody, but it can restore function. About 25% of people out of a wheelchair walking again. It can have tremendous benefit in people by the mechanism that's on the next slide. So here we have an action potential going down. You want to move your leg. You can see the little sausage structures are your myelin, while you have an MS lesion there in the blue where the little yellow guys are, and potassium is leaking out, and your signal's not going forward very much. You can see the weak dotted line across. Now, you go on Empira, next slide, and it blocks the aberrant potassium channel. So more signal goes effectively to where you want it to go and consistently. So it improves endurance and strength. Next. Spasticity is the stiffness associated, which a lot of people have very stiff gaits. If you treat it too well and there's weakness in the legs, they don't have their strength anymore because you took away the tone and they can become weaker. So sometimes treating the spasticity is a really fine art of you need a little bit to limber up your legs. Too much is going to make you not be able to walk until the medicine wears off. So there's a lot of things we have that we can use to treat that. Next. Bladder dysfunction, very, very common. You can have a spastic bladder or you can have a retentive bladder. Spastic bladder is, I got to get to go to the restroom, you let out 5 cc's, okay, I'm done. 5 minutes later, I got to get back to the restroom and release some more. It's just a spastic or spasm of the bladder. And when you have bladder issues, you really don't want to go out in public necessarily. You don't necessarily think about intimacy if you're going to leak a lot unless you have a good, healthy discussion. So it's a very important issue. It usually leads to poor sleep, having to get up to go to the restroom 4 or 5 times. You don't have effective sleep. It can lead to ulcers of the skin or bed sores, and it often leads to frequent UTIs when you're not able to release all your urine. The bacteria can take a hold in your bladder, and then you have problems. Next. So this is a partial list of different things that you can do for a spastic bladder. Some Botox in the bladder, there are some devices, some stimulators of the bladder that can help. Next. Pelvic floor therapy is a big thing that's come along that can really help from a therapy standpoint. Retentive bladder is more that you've lost the nerve supply to your bladder and that sac just fills and it doesn't do anything. You don't get any stimulation that you have to go. So you have an overfilled sac and you just leak out some from time to time. So a lot of people will push on their lower abdomen or pelvis to try to let the urine come out, trying to push that sac to release some of the urine. There are some various treatments listed there. And again, pelvic floor therapy is something that can help. This came about during COVID. Pelvic floor therapy really took root, so a lot of people didn't know about it. We didn't talk about that in talks around because we didn't have the talks around. But pelvic floor therapists are very good at doing things that are not just Kegel maneuvers. They do a lot of things that can help you gain better control of your bladder, your bowel to some extent, and vaginal wall strengthening. Next. Bowel dysfunction, constipation, more common than diarrhea, but both are present in a number of people with MS. You want to make sure that those who can't control their urine, they have very urgency, usually it's very soft, is to bulk up the stool so that it stimulates the inner wall of the colon to allow your brain to know that the stool's coming down. Because when it's very thin, it may not distend the wall. You don't have any idea it's there until it's there. So there are some medications for urgency, but a GI doctor can be very helpful. Sexual dysfunction, we don't talk about because Stuart's going to give me the yank in a minute, but from a time standpoint. But this is something that people feel a little uncomfortable talking about. But intimacy is very important in our lives. So if you're having difficulties in this arena, know that MS can do this, can cause problems, and hopefully you have an avenue or a comfort level with your healthcare provider, whether it's your MS specialist or urologist or gynecologist, to discuss these issues, because there are many things we can do to kind of help out this situation. Next. Communication, understanding, very, very important. Certain medications can be helpful, and there is a pink pill. So there's a blue pill for men, and there's a pink pill for women. The pink pill works more on libido in the brain than it does structural functioning. But we didn't have anything forever for women with difficulties, sexual dysfunction. Testosterone levels can be low, unrelated to MS, and we're treating an MS-related problem that isn't an MS-related problem. It's a low testosterone level. So think that other things other than MS can cause some problems, and make sure we're addressing those potential problems. Next. Difficulty swallowing, choking on saliva or liquids or food. Silent aspiration occurs a lot, which leads to pneumonia, which can be a very dangerous situation, especially those more severely affected with their MS. There are medications that can help, and some specialized straws. Speech therapy has a big place to help us in that scenario. Next. Ooh, it's painful. So that was me at an Auburn game watching Alabama lose. So pain. There are a lot of different kinds of pain. When my mom was diagnosed with MS at Yale in the 60s, they said, well, it's terrible that you have MS, et cetera, et cetera. If there's anything good about this, you won't have any pain and you won't have any cognitive problems, because that was the thinking a good 60 years ago. We know differently. Pain very commonly occurs. My mom had 3 teeth that were taken out because of trigeminal neuralgia. They thought it must have been a tooth. It was really the nerve, and she lost several teeth for that reason, for ignorance. So pain, if you have pain, yes, it can be related to MS, and you should address that with your healthcare provider. Next. Comorbidities. Comorbidities are conditions that are genetically also associated with MS. They come along as a partner, and I'm just going to talk about the next couple. Next. This is a list of things that are genetically co-linked with MS. So you have a higher incidence of having these conditions because you got the genes for MS, you got these genes as well. Next. Depression. It can be due to lesions of MS, but it also is a genetic problem. We treat people with depression and anxiety horribly. It just reminds me of Salem, Massachusetts, where we burned women who had seizures. They were witches, right? They had epilepsy. So how do we treat people with depression nowadays? Oh, Johnny across the street's in a wheelchair. What are you so depressed about? Oh, you're not praying enough. If you pray more, your depression will go away. Oh, this reason and that reason. You need to be tougher. Do we say that to the diabetics? Do we say that to people with Parkinson's? Do we say that to people with MS? No. It's a physical problem just the same. It happens in this organ. It's a chemistry that's off, just like diabetes is a chemistry that's off here. Why do we treat people like that? They already feel guilty, and it creates a whole lot more isolation. It's a real medical problem that deserves treatment. You wouldn't ignore diabetes. You shouldn't ignore depression. It's not that you're weaker. It's not a mental health problem. It's a physical problem. Now, there are things that make it worse, that may be worthy of going to see a mental health specialist. But stress makes MS worse. Stress makes diabetes worse, but you wouldn't say stress caused diabetes or stress caused MS. It didn't cause your anxiety and depression. It made it worse. So we need to treat people with respect who have those conditions that we seem to think they should be able to garner control over those problems. They can, and it leads to suicide, it leads to isolation, it leads to horrible things. So I think those comorbid conditions, depression, anxiety, extremely important to have a keen understanding about in this condition. Pseudobulbar palsy, this is something where you just cry without any ability to control it, or laugh inappropriately at a funeral, for example. This is due to a certain pathway in the brain that's affected by the MS, and we have treatments for it. So another thing that can socially isolate people, I don't want to go out because that may happen, so more restriction inside the home and inside the person. And as I said, stress is bad. So I think all the rest is kind of those extra things that were not a part of this topic. So I know there's time, and I'm seeing Stu over there ready to ask the questions.
So we're ready to pull the plug.
Okay, that's fine.
Everybody,
I'll be happy to answer questions.
Let's thank Dr. LaGanke.
You said something about pain and centralized itching.
Yes.
I have, for the past several years, had itching issues with my scalp, and my dermatologist can't figure out how to treat it. Any ideas?
So the question is about, in the pain category, and on the slide, which I kind of glossed over for time purposes, was generalized itching. And generalized itching, or itching pain even, where it's that fine line between is it itching or is it painful, occurs related to lesions with MS. So some of the lesions release histamine, which causes this itching that you just can't get at. It can be in the hands, it can be in the scalp, it can be in different parts of the body, and you scratch and it just does not relieve the itch. And that's due to a nerve release, due to one of the lesions of histamine that causes that. So we typically will employ antihistamines or anti-seizure medicine. So if you stop the nerve transmission, you stop the release of histamine, and they can be effective. On the other side, you can give the antihistamine, so the histamine's released, you give an antihistamine, then it doesn't have an impact on itching. So those are the two things that we typically, are the categories that we'll use to try to help that central itching.
Can you talk about neuroplasticity and how it affects movement and walking and physical dysfunction?
Yeah, that's a deep question about neuroplasticity and the effects of walking and other things. So neuroplasticity is the ability to generate function because you have reserve in your brain or in your spinal cord to overcome a problem that you had. So if we're neuroplastic, we can generate strength when we had weakness, let's say, if we're talking about weakness. Or we can learn new things because the brain has reserve, and we're utilizing that area of the brain to improve synapses and signaling, and then we can gain better function there. In walking and in strength, unfortunately, to the present time, if there's a spinal cord lesion, we can only generate so much electricity through that lesioned pathway in the spinal cord. And you can try all you want, rehab therapy and so on, but after maybe a brief improvement, there's just nothing more that one can do for that. Now, you can improve signaling, like I said, with dalfampridine. Sometimes that's very helpful. It allows more signal to go through the scarred tissue, and it's not shorting out, and you can regain function. But unlike stroke, where neuroplasticity works great, so patients regain strength from stroke a lot because they can bypass the area of damage, which is typically up in the brain, and they can generate new pathways around that. And the way a stroke heals is a little bit different than the way an MS lesion heals. But when we're talking about spinal cord injury, it's very hard to utilize neuroplasticity at this point. Now, if we could somehow stimulate the area below the level of injury, that would be great. So the walk aid, for example, that electric device you can put around your leg if you have a foot drop, if you can stimulate the nerve, your foot's going to work fine because there's not a problem with the leg. It just doesn't move. And it doesn't move because it's unplugged. So if you unplug the circuit above, if you can stimulate that nerve circuit below, it should work just fine. So if we have ways to improve stimulation of the nerves in the body below the level of injury, will regain function. And so that's what the walk aid is, and the Bioness device, that's what they're designed to do to help someone overcome the weakness from a foot drop. If we could get something for the hip flexor, which raises our leg up, that would be dynamite, because that's the one muscle that really leads to a ton of disability in individuals with MS and other conditions.
All right, person asks, so their first question was, could mitochondrial dysfunction be an underlying cause of MS? And also, given that about 99% of us with MS had EBV, mono, could the virus have penetrated the mitochondria within our cells to change the entire makeup of our DNA?
Can you repeat the very first part of that question?
Okay. Could.
Thank you. Will you please?
Could mitochondrial dysfunction be an underlying cause of MS?
Probably not the cause of MS, but certainly a part of MS, but probably not. There are a lot of mitochondrial disorders that we know about, although I think it's more of a secondary effect than a primary effect in individuals. The second part of the question with Epstein-Barr virus, a lot of interest has come up recently with an article in news that's come out about Epstein-Barr virus. Epstein-Barr virus is a virus that typically causes mono in individuals. 95% of the people in this room, adults, have evidence of having had mono, even though you may not remember an episode of mono. So Epstein-Barr virus is exceedingly common in community. But back probably 2 decades ago, when we looked at children with MS, we wanted to know if Epstein-Barr could be a cause of MS. And so we looked at children who had were diagnosed with MS, and then we looked at age-matched children who went to the emergency room, so same-age children, and drew blood in the children with MS and the children who were the same age and sex and such. And we saw a much higher incidence of Epstein-Barr virus antibodies in the children who had MS compared to those who didn't. So that we can't really do that in adults because everyone has antibodies to Epstein-Barr virus. So that I think told us that Epstein-Barr virus in a number of people causes or likely leads to MS down the road. Not everybody, but a number, and we can't necessarily quantify it. What Epstein-Barr virus does is when you contract it, it gets into your DNA. That's a problem. Your DNA has certain turn-on signals, turn-off signals, and it's due to 3 amino acids in a row. So if you had an A, a U, and a G, that's going to tell you to start processing and make a protein. Well, if Epstein-Barr virus gets into the DNA, that shifts things. So now you're making some kind of protein over here that isn't what you wanted when you had a problem that you needed a certain protein to be made for. So Epstein-Barr virus wreaks a lot of havoc in individuals. It doesn't mean that you still have Epstein-Barr virus in you. There's a lot of talk about that because you have a lot of antibodies to Epstein-Barr. It doesn't mean that the virus is necessarily still there, but it can be really gone and intercalated in your DNA and cause a whole lot of problems. So treating it at this point with what we would maybe treat Epstein-Barr isn't going to be terribly helpful in the majority of cases because it's not circulating, it's not in tissue, it's decided to implant itself inside your DNA. So that's something we can't at this point eradicate. Don't know how to manage that at this point, but I know there's a keen interest in that now, and I'm sure some bright minds will figure out avenues.
Thank you for that. Next one, I'm combining 2 questions, and then I'll get to the other side of the room. So a person is, different people are asking, if there is no known lesions for a few years in their MRIs, should they continue with their MS therapy? And part 2 was, for those that are over 65, not showing any new lesions of any type, and their symptoms are at bay, should they stop their therapy?
Yeah, so those are great questions. We certainly would love to have a good answer because we certainly don't want people to take things that they don't need, that they're not really going to expect much benefit from. And there have been some studies that have addressed this. I think the first part of the question, it really depends on age. So if you're young and you've gone a few years on your disease-modifying therapy and haven't had any relapses, that's fantastic. And coming off your treatment is Russian roulette at that point. We don't know what's going to happen. It's like someone who has hypertension and they take their blood pressure medicine, their blood pressure is great. So it's great for 6 months. Should you come off your blood pressure medication? Generally doesn't work so well. B12 deficiency, same thing. Those medicines are controlling the problem. They didn't fix the problem. And so typically, we're not going to come off DMT therapy early on. Now, there have been several studies through New York University looking at 65 and older, haven't had disease for 10 years, no relapses. Should you go off your medication? First study, about 50% of people were having relapses, over 65. They hadn't had it in 10 years, and 80-year-olds having relapses. That didn't look too good. But decided to do another study, because there might have been some methodological issues, and that study showed that it was a small percentage of people in that scenario who went on to have more disease activity over the duration of the study, which said, well, maybe a fair number of people, if they're really well controlled, hit a certain age, their MS is kind of burned out, they don't need to be on therapy. And then a third study kind of mirrored the second study. So it's something definitely that I think should be determined on a case-by-case basis, not a global, everyone who's in this situation should go off or not. It probably depends on comorbidities and whether if a person's just cruising along and they take a hit from a relapse, maybe they can manage that better than someone who's teetering with a walker. If they have a relapse, they'll never walk again. Maybe they don't want to take a chance of coming off their medication just by the off chance that they're going to have a relapse. So I think it's kind of an individual answer there, but something that we would love to have an answer and find different subsets to say if you only had 2 relapses, if you only have this lesion burden, if you're like this, you can pretty well come off your medication and have a high chance of not having any more disease activity. We're not there yet, but it's a very hot topic as far as figuring that out, and I think we will have an answer before too long.
Thank you much.
Do you have any thoughts or opinions on stem cell research as a treatment for MS?
Yes. The question was opinions, thoughts on stem cell therapy for MS. This has been talked about over 20 years. So excited. I mean, my enthusiasm for that back in 2000 was really, hey, we have a potential to really fix MS with this kind of therapy. Stem cells are naive cells that if you put them in a knee, they'll do stuff as a knee joint. If you put them in the brain, they'll do brain stuff. You put them in the heart, they'll do heart stuff. So stem cells are cells that can be turned into most anything. So if you put them in an area of damage in the brain, the hope is they're going to fix and rewrap the myelin and the damage that's in the brain, amongst other things. So really excited that this is a potential fix for MS. We're 20-something years later, and unfortunately, that's not a standard treatment. It hasn't gone to the point where, that's an absolute yes. I still am very enthusiastic about stem cells and their potential benefit in multiple sclerosis. Some of the problem is that you get a study of 10 patients in Europe, in England, 10 patients in Spain, someone in Denmark, someone in the US. They use totally different protocols, and they have different results, so we don't know what to actually do. So in Europe, they passed a law that said anyone doing stem cell therapy has to do it under this protocol. So we can get some meaningful data to say, yes, this done this way, we have very good results, and this should be something that's approved and offered to people who are affected with MS. There's a lot of interest in the United States. Some people get stem cells. They pay out of pocket $20,000, go get stem cells. You want to be very careful because there are some shysters there who they may give you salt water. You don't know that you're getting stem cells necessarily, and they pocket the money. Unfortunately, that's in every facet of our life. So you have to be very cautious about those individuals who claim X, Y, or Z, and you want to do your homework and make sure that there's some credibility and maybe some other people who've actually gone through that experience who can verify that they had this or that result. So we're getting closer. I've said that a long time, so I'm a little less enthusiastic to be, hey, this is it. I think it can be it, but it's taken a long time, and past anxious to have this here already because I think it has potential. But there are other issues such as how do you put it in the brain or spinal cord? Do you do it through a spinal tap? Do you drill a hole in the brain and put them in that way? Do you give it in the blood and then give them some medicine that opens up their blood-brain barrier, which might introduce some other things into the brain that we don't want for a short period of time to get them in there? How much is too much? If you get too many stem cells, is it going to create a cancer situation where you have overgrowth? So there are a lot of logistic things that are being worked out to finalize what's the best way to administer this and have a really good chance at positive outcomes. We've come a long way in 20 years. I don't mean to say that we're just in the same drawing board situation as we were there. We're with a lot of really good people pushing this issue to get success, and there have been small studies with outstanding results. We need more results to show that this is something that a person would want to take. So,
Doctor, can you also go into the negatives of going for offshore for these stem cell replacement therapies and the people that get sick and then have nowhere to turn?
Yeah, there was, with ALS, there was a stem cell area that people would go to, and the promise was such positive results, and it was all a sham. And that destroys stem cell research for the rest of us who want it to work. That gives it a bad name, and so we need to kind of root out those people who are just trying to make a name for and some plagiarized or falsified information in their trials to make it look better than it was. And it's not the stem cells' fault that you have bad people in the world. And it doesn't negate the fact that it still can be a very, very effective treatment. But we just have to be careful. So overseas, I had a patient, orthopedist, who went down to a certain country. He just continued to tank and went back for a second because desperate situations require desperate solutions sometimes. So he was like, what do I got to lose? Just worse, 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 absolutely no effect. I don't know what he got, and it's not regulated in some of these places. There are some in other countries that are regulated rather well, but there are some that are not, and I think you really want to do your homework before you invest your time, money, energy into something like that.
So to boot on that, we have heard people that have gone down to certain countries in Latin America and Central America that came back and got really, really sick. And their doctors here had no clue what was put into their bodies there, and they didn't know how to treat it either. And unfortunately, some of those people have passed.
Yeah, and so we've had that experience with a couple of people. Don't know what they got. Maybe nothing, and maybe their condition just lit up because they didn't have anything. And they came off something in hopes that would work. But so to be very, very cautious. People are going to pray. I mean, with the world of influencers, say some things that are partially true. They just prey on people's desire to have a positive outcome. And they say, I'm desperate, and they promise this, I'm going to go do it. And you just have to do your homework.
Okay, thank you. Before I get to the center of the room, I promised this person online that she's next. And she says, I haven't had any new lesions on my MRI in 12 years and have never been given any of the new medications. I do have progression of the disease, now walking with a walker and minor brain involvement. I feel left out and degenerating without any medical help. What can you suggest?
Well, I'm sorry that's happened. It sort of goes along with this talk that you can get worse without any obvious relapse or new lesion. And one, you have to make sure that all the areas were imaged. So if it's just, I don't see any new lesions on the brain, well, did we look at the spinal cord? Did we look at all aspects of the spinal cord? Maybe there was a lesion there that occurred that really kind of devastated a given individual. What kind of MRI is it? Is it an open MRI, which is about 1/10 the strength of our strongest MRIs? Was it sliced very thin or just very thick slabs? So you're going to miss the fact that there are new lesions. So you want to make sure that the scanning was appropriate. And if so, and there were no new lesions, and you're having worsening of your condition, and we've ruled out other things that may cause the worsening of your MS, well, I think that's a discussion to have with the healthcare provider about the value of changing the DMT to something that's a little bit more aggressive.
What is the correlation between Alzheimer's and MS?
Alzheimer's?
Yeah. Is there anything?
So the question is there a correlation between Alzheimer's and MS? And to this point, I think there may be some common gene here and there, but really nothing that someone with MS, we expect them to develop Alzheimer's disease. That's, at this day and age, that's not the expectation. Now, a person with MS can have a lot of cognitive issues, can have a lot of brain atrophy, can behave a bit like someone who has Alzheimer's disease because they have a heavy hit in their memory area of the brain. So one can look like they have Alzheimer's, a person who has MS, and MS definitely can affect cognition in a number of ways that share cognitive problems with people with Alzheimer's disease. But it's not expected at this point that a person who develops MS is going to develop Alzheimer's from their MS. All right? Now, if there's family history of Alzheimer's, that's a different situation. I haven't looked at that particular part of it. I haven't seen anything on that, but I haven't looked at that in a while, so I'm saying that with the knowledge that I have prior to. But I would expect that if there was a good bit of reliable information out that says that a person who has MS can expect to develop Alzheimer's, that we would know about it.
Is there a way to prepare for a planned future stressor? I don't want to fall back on my current disability.
Stress definitely worsens MS, and I wish we could anticipate what sort of stressors are coming our way. You can do that with heat. You can do that with other situations. I think if you have people around you that are negative and you don't have to be around them, that's probably a good thing to do. That plan not over-volunteer if you're a good-hearted person, as many are, and you over-volunteer, you can definitely cause a weakness in your MS and a worsening of your MS. So those are sort of stressors that you could kind of anticipate might happen and do something about them so that they don't cause worsening of the function. But as far as just stress in general, I think it's very difficult to anticipate that. Menstrual cycle, increase 1 degree temperature, that can cause problems for certain times of the month, so you may anticipate that and do things a little bit differently, not plan on doing a lot of arduous work during that time, or so those sorts of things. But just stress in general, I'm not sure there's not a test you can do to say a stress is coming on in the future.
All right, next one. Thank you for that. The next one is, what can you tell us what kind of the best supplements for people to use that have MS?
Just supplements?
Supplements. Vitamin D.
Yeah. So you want to make sure that your vitamin D level is appropriate. And that's true for all of us. And it's good for bone health, et cetera, et cetera. With MS, there is some suggestion that low vitamin D does make the condition worse. I think in general, if you're on a good DMT, the contribution of vitamin D compared to an effective DMT is very low, but you should have a normal vitamin D level anyway for generalized health. There are a lot of supplements out there, and a lot have testimonials on the internet, and we don't know. I mean, the honest answer as a healthcare provider is, I don't know what this does because it's not been studied. A lot of these supplements, natural things, may have some good 5, 10, 15 people, but there's a placebo effect to everything. And if it's not done in somewhat of a large study, we can't really attribute the positive outcome to the intervention unless we have another arm that controls for that. Now, what I see a lot of, unfortunately, what I see is a lot of healthcare providers say, oh, that doesn't work, that's a bunch of baloney. We can't say that either. We can just say it's not studied. We don't know what this supplement or that. Some people have claimed that it's helped them, and that's fantastic. But I can't go out and say scientifically with rigor that there's a positive benefit. And when you watch things on TV, anything that's natural, organic, they don't have to be accurate in what they say. They don't go through the FDA. They can say whatever they want to if it's natural or organic. So you hear it, and they put a lot of money into, oh, this is good for brain health or your memory. Go take this. That's not necessarily true. And we wish that there would be more control of that and actual studies that help us. I'd love for a lot of supplements and natural things to help in a lot of different ways. That would be wonderful. I would jump on that any day. But I have to do it responsibly and scientifically. So maybe that partially answers the question.
You know who I am, Melanie Lippum. I'm the founder and president of the Society with MS. And a lot of people in my Facebook group, this is an ongoing question of what about the people who have not tested positive for EBV? So do you think it could also be, because it's in the herpes family, that it could be any herpes virus, like shingles, chicken pox, or any other virus for that matter?
Okay, thanks for the question. The question is there are some people who have MS and they do not test positive for Epstein-Barr virus. They don't have evidence of antibodies against Epstein-Barr virus. Since Epstein-Barr virus is in the herpes family, could it be a different herpetic virus that does that, like CMV or herpes simplex 1 or 2 or other herpes-type viruses? Yes, and human herpes virus 6 was studied for a while in the past because we found evidence of it in MS brain lesions. And so that was looked at for a while. It didn't have a high percentage, so it kind of lost interest. But I think MS is not caused by one particular virus or one particular substance. That's what makes it so enigmatic for all of us. I think it has to do with what genes you have. There have been over 150 genes identified that make a person susceptible or contribute to MS. So one person may have gene A, B, and C, and that requires them to be exposed to Epstein-Barr to get MS. And another may have X, R, and T, and Epstein-Barr is not going to cause MS in that individual, but human herpes virus 6 will. So I think that we can look for some of those other viruses to see if they're present, but I don't know that we have enough information to say that if you had evidence of, a cold sore and HSV-1 antibody, that's what caused your MS. We're not there yet. I think Epstein-Barr definitely causes MS in a number of individuals, but we don't have great evidence. Some people looked at chlamydia. They spent their whole life looking at chlamydia as being a cause of MS and have some good information. Some people looked at measles back in the day, and there were measles. So maybe in some people, measles was the thing that led to the cascade of events that caused MS. So I think there are different things that can cause it. I don't think going down the herpes simplex or the herpes virus testing in those who are negative for Epstein-Barr is going to answer anything. They may or may not have a positive test, and it may or may not contribute to it.
Thank you. Currently, one more question online, and then when I see we have another question back in the center of the room, so we'll be there in a moment. And would the normal MRI of our brains that we get yearly show if there is damage in the thalamus, and what does that show?
Yeah, so a good MRI scan of the brain will likely identify problems or lesions that occur in the thalamus. We also use thalamus size and third ventricle size to tell us about brain atrophy and help us to measure brain atrophy over time. So it can indirectly help us in seeing if there's advancement of MS in the brain without there necessarily being a lesion in the thalamus. But yes, we should see lesions that are in the thalamus if they're there with a good scan.
Is there a genetic link to MS?
Yes. So the question is there a genetic link to MS? And the answer is yes, it's a genetic condition. Fortunately, it's not a blue eyes, brown eyes kind of genetic contribution. So for me, with a mom and MS, I have a 97.5% chance of not developing MS. There's a 2.5%, and the other way to look at that is a 2.5% chance. The chance or statistics in common society is 1 in 1,000. So it's 25 times greater chance to develop MS if you have a family member with MS, but it's a very low risk. It's still 97.5% chance you're not going to get it with a parent who has MS. Now, there are other things. I have families who have 5 siblings that have it. Their genetic makeup is such that they strongly pass on a particular gene that makes a person susceptible. So there are nuances to that, but just as a general rule, without any of these other odd situations, it's a very low risk to pass it on, but it is higher than the general population. Still less than 5%.
It's great. Thank you.
You're welcome.
Now let's all say thank you again, right?
Thank you. Thank you. Thanks very much.
You're very welcome. Very welcome. Great. Good night, everybody.